Ladies and gentlemen, during the following 15 minutes, I will present you an update of the history, the current status, and the future developments of surface coating of vascular implants. This presentation was made possible through the collaboration with Dr. Lenz Havian from Phenox. The first image is taken from a recent publication. The authors exposed different flow diverters to human blood in a pulsatile flow loop model. The lumen of the uncoated flow diverters, the first three rows, these are Derivo, P64 Classic, and Pipeline, was filled with thrombus, which was not the case with Pipeline Shield. This flow diverter is coated with phosphoryl choline and shows a reduced thrombogenicity. With the first stent treatment of an acute myocardial infarct in 1991, the need for an accompanying medicinal treatment to avoid thrombus formation became very obvious. Aspirin and ticlopidin were used initially. However, ticlopidin was soon replaced by clopidogrel, which is more effective and better tolerated. The first coated coronary stent was implanted in 1999, so it's still quite new technology. The goal of coating coronary stents with drugs like paclitaxel and sirolimus was an inhibition of the vascular cell proliferation in order to prevent in-stent stenosis. This coating does not reduce the thrombogenicity of these stents. These are examples for second generation coronary stents, drug-eluting stents, and newer stents. The so-called combo stent combines a sirolimus abluminal coating on this outer surface with an antibody coating on the luminal, the inner surface, and the anti-CD34 antibody triggers the capturing of circulating endothelial progenitor cells. These cells result in a self-endothelialization of the implanted stent, and this allows a shorter period of dual antiplatelet medication. This is a very specific concept which has nothing to do with reduced thrombogenicity. It is a more biologic effect. The concept behind the polysine F polymer nano coating is essentially the same. The coating allows coronary stents implantation with only 2 weeks of dual antiplatelet medication, but the acute thrombogenicity is not reduced. The challenge in neurovascular stenting comes with a need for dual antiplatelet inhibition. If we give aspirin and Plavix, the risk of spontaneous intracranial hemorrhage is increased. Even minor surgical procedures like external ventricular shunting may cause massive intracranial hemorrhage. We encounter non-responders to all antiplatelet drugs we know today. Drug interactions very important is the interaction between aspirin and ibuprofen, and situational changes in the dosage requirement. So if a patient has fever or any other inflammation, the need for aspirin, the dosage required for aspirin can easily be triplicated. The perfect coating, from our perspective, would allow the device implantation without any accompanying medication, and a coating which allows the device implantation with the use of only one reliable drug is only one step in the right direction. Gold coating was evaluated and thus per se not reduced the thrombogenicity. Hirudin, it's similar to heparin coating, has only short-term antithrombotic effect. So that's the issue with all heparin-like coatings. They are effective at the short term, but not sufficiently lasting. Another very interesting concept was diamond-like carbon, DLC. It also does not, it has certain biologic effects, but it does not inhibit the thrombocyte adhesion, so it does not sufficiently reduce the thrombogenicity. It has very nice anti-inflammatory effects. Heparin clearly inhibits thrombocyte adhesion. The duration of this effect is too short to avoid dual antiplatelet medication. This is important to remember because later I will show you examples of new concepts to coat flow diverters with heparin-like surfaces, and it's very unclear if this will really solve the problem. Back in 1984, Hayward and Chapman demonstrated the so-called thromboresistant features of phosphoryl which mimics the cell surface of red blood cells and quiescent platelets. So one of the common concepts is to work with simulation of biological behaviors, like in the case of phosphoryl to simulate the surface of erythrocytes. Pipeline shield is a flow diverter with reduced thrombogenicity, and this is achieved with phosphoryl surface coating. So it's absolutely not a new technology, but it's a new application of an old idea, phosphoryl similar to red blood cells. The surface of the erythrocyte bilayer inhibits platelet thrombus formation on stents and flow diverters. Again, shield. A dramatically reduced homogeneity of the pipeline shield compared to the uncoated pipeline was confirmed in vitro by Gerhard et al. In 2015. In vitro is an important aspect because the animal models for evaluating these coatings and devices are very difficult, because for most animals the coagulation system is pretty different from the human circumstances. So it's most likely, at least in the beginning of such a development, better to go for human blood and do it in vitro than using any animal model like rabbits or pigs. The surface of the erythrocyte bilayer inhibits platelet thrombus formation on stents and flow diverters through the effect of this hydrophilic head and hydrophobic tail. So you have molecules on the surface of the erythrocyte and of the device which have both effects. In the following study, PET shield was found to be less thrombogenic than the Revo P64 classic or uncoated, and pipeline uncoated. This only confirms that there is definitely a phosphoryl effect on thrombogenicity. The Revo flow diverter has a surface finishing. It is not really a coating, called Bluxide, which does not reduce the thermogenicity of this device. There's some confusion. This Bluxide is effective in modifying the surface, but it has no confirmed effect on any aspect of the thrombogenicity. Scanning electron microscopy images obtained after 90 minutes incubation in human blood illustrate very well the different extent of platelet and thrombus adhesion on the surface of the different flow diverters. You see here, this is the Revo P64 classic pipeline and pipeline shield. And pipeline shield, the coated version, has very little thrombus adhesion on the surface if you compare it with pipeline, and of course with P64, way more material, and the Revo. HPC is a totally different concept. It is hydrophilic coating based on a glycan-based polymer, which is covalently bonded on the nitinol surface. This is the tricky part, how to get the surface really sticking permanently on the surface of the implant. While phosphoryl is mimicking erythrocytes, the coating HPC is mimicking the glycocalyx, the inner liner of the vessel wall. What does it mean? The in vitro evaluation was done with nitinol dishes, little pieces of nitinol. They were exposed to human blood for 10 minutes, and these platelets, the platelets adherent to the surface, were visualized with fluorescence microscopy. The uncoated surface, this is on the left side here, of the images, shows a very dense coverage of the surface with platelets, and the HPC-coated surface on the right-hand image has almost no platelet adhesion. So this is a very elegant and relatively simple method to evaluate how anti-thrombogenic a surface treatment actually is. The same experiment, in vitro experiment, has been done with branched flow diverters with the same result. You see here, this is the bare surface, a lot of CD61 positive signals from the surface, and this is the same implant. P48 HPC, literally no signals from CD61 positive adhesions. These exposures are on stagnant blood. The blood in the human body is usually flowing. So to simulate the circumstances of flowing blood, the so-called gentler loop is used. It is mimicking blood flow conditions and allows blood exposure for 2 hours. So in this gentler loop, you have tubes which are on an axis rotating continuously. The tubes are filled with the test implant and with human blood, and you can see the extent of surface adhesion over 2 hours. These are electron microscopic images demonstrating the difference of thrombus formation on the bare surface on the left side and on the coated surface on the right side. You see it's a major difference. All these are surface adhesions. It's both blood cells, platelets essentially, and blood proteins, and literally no surface adhesion on the right image. On a side note, the concerning publication with these in vitro experiments was awarded as the most cited laboratory investigation particle in the journal CVIR. Apart from the sheer antithrombogenic features, it is necessary to test the biocompatibility, and this was done in a semi-chronic animal model for P48 uncoded and HPC coded. They were implanted into the ICAs of rabbits, left there for 30 days and explanted. And this image shows the bare surface and the HPC surface, and there is no the altered tissue response compared to the uncoded device. So there is no induced inflammation by this antithrombogenic surface coating. What is evaluated is the inflammatory reaction, the healing, and the neointima formation. CD31 mimetic coating favors the endothelialization of vascular implants in a very similar way like polysine F. In addition, CD31 mimetic coating in vitro has been demonstrated to reduce the platelet adhesion on the implant surface. This is a project of BALD. For CD31 mimetic coating, the level of thrombogenicity immediately after deployment remains to be determined. To our knowledge, it is not yet confirmed if these CD31 coated devices can be implanted without dual antiplatelets. So this is a critical part. It is not clear if any reduction of the surface thrombogenicity is or is not enough to reduce the thrombogenicity to a level that allows a deviation from the traditional dual antiplatelet medication. The next project is Derivo, or coding concept is Derivo Heal. These are in vitro results demonstrating thrombogenicity of bare and fibrin-coated surfaces, and this is reduced by heparin. So the coating of Derivo Heal has been shown, and this has been properly published, that it is fully biocompatible. The degree of reduction of thrombogenicity is not yet clear. FredX is another technology. It's called X coating. It's covalently amphiphilic surface modification of the entire implant with a very thin, less than 10 nanometers thickness. Amphiphilic means hydrophobic and hydrophilic components in the same surface. The hydrophilic component generates a permanent layer of water molecules on the surface of the implant. This water coverage prevents protein and cell adhesion and reduces the friction during microcatheter passage. This might be a good aspect for several implants. For the majority of the today available flow diverters, I would say it's not a big deal. Most of them can be implanted without friction issues. But anyways, the friction is reduced. The hydrophobic component, that's the second aspect of this coating, serves as a spacer. It stabilizes the hydrophilic polymer brushes and improves the sliding properties. Again, the hydrophobic surface has self-cleaning features, and water erodes off and takes away everything that is not really firmly fixated on the surface. Microvention. FredX is the coated surface, the surface coated variant of the microvention flow diverter. X coating was originally developed for extracorporeal devices and infusion bags, and has been shown to prevent thrombus adhesion on the surface. Initially, microvention did not officially claim to decrease the thrombocyte adhesion of FredX. Recently published papers showed that FredX is in vitro less thrombogenic than Fred and PET Shield. It is, however, not known if FredX can be implanted under a single antiplatelet therapy. In the meantime, Stryker, and I think you can sense the pressure for these companies, right? These medical device companies are now they feel obliged to come up with any efficient surface coating. That's also true for Stryker. Stryker announced that their Surpass Evolve flow diverter will receive an antithrombogenic heparin coating. It's Kameda, and this has been developed by Gore and has been used in other implants. It is a heparin-based surface coating, and clinical practice has to show if this surface coating will stay long enough on the surface of these flow diverter implants. The currently strongest antithrombogenic effect has been demonstrated for PET Shield and P48 and P64 HPC flow diverters. The feature of accelerated endothelialization alone has limited value for neurovascular indications. It could, however, create a significant added value for antithrombogenic implants. So this table shows a summary. So for HPC and Shield phosphorylcholine, we know that both surfaces are less thrombogenic than all the others. Little is known about the healed surface developed by Henkes. The same is true for CD31. It comes with some reduced thrombogenicity and accelerated ingrowth. Polycene F has no reduced thrombogenicity, but a significantly accelerated ingrowth. So, for instance, for a short-lasting surface, an added feature like this, like it comes with Polycene F, could add significant value. Very little is known about FredX, and it's simply unknown and not evaluated if FredX flow diverters can be used with single antiplatelets. And Obus Niche has another surface modification with accelerated ingrowth of the implant into the vessel wall. Standing without antiplatelet medication is currently not on the horizon. We don't know how this could work, but standing with prasugrel only single antiplatelet treatment has become our daily routine, and we recently published the first, this is more than 100 aneurysms treated with prasugrel only. Thank you very much.